Hello, everyone, and welcome to our Billings Clinic Grand Rounds. This is our second talk in a special series focusing on COVID-19. We want to especially welcome our colleagues across the state who have joined us today. My name is Ashley Dennis, and I'm the Director for the Office of Medical Education here at Billings Clinic.
Thank you, Ashley. And I'm Dr. Ginny Mole. I'm Medical Director of Education and the DIO for the Billings Clinic. It's our great privilege to welcome back to this forum Dr. Neil Koo. Dr. Koo joined the Billings Clinic in 2019. He is our healthcare epidemiologist. He did his undergraduate at Spring Hill College in Mobile, Alabama before going to medical school. Also in Mobile, Alabama at the University of South Alabama College of Medicine. He did his residency at the University of Arkansas in Little Rock, Arkansas, and then did his fellowship in infectious disease at the University of New Mexico in Albuquerque, New Mexico. Dr. Koo, I'm so excited to have this opportunity to hear from your perspective the updates on treatment of COVID-19. Thank you for joining us.
Thank you very much, Dr. Mole, for that introduction. I'm honored to be here today to give a quick update on the treatments of COVID-19. I would like to have this presentation, the first half of it, which is for me to kind of go through very briefly some of the treatments that's been used in the management of COVID-19, and then for the latter half of this presentation, a discussion with a panel discussion on our local experiences with these treatments. With me, who will join me with the panel discussion, will be Dr. Greg Holtzman from the Montana Department of Public Health and Human Services. We'll have Dr. Evan Bell, who is one of the infectious disease physicians here at Billings Clinic, and we'll also have J.C. Ott, who is the infectious disease pharmacist, who has been very, very helpful in helping with in managing the treatment of COVID-19. So just to start, let's see if I can get this to work. So my objective today is just threefold. One is to review some of the treatments that's currently being investigated for the management of COVID-19. Also, we'll review some of the available data on the efficacy of some of the select treatments, and then as to follow up with this, we'll kind of have some discussion with local experiences and challenges in the management of COVID-19. So just to start, there's some want to kind of briefly have an overview of, on the epidemiologic data of COVID-19, and this is actually as of today. So that look for the U.S., there have been over 8.4 million cases of COVID-19 diagnosed since the onset of when this was first identified in the U.S., and that since then. From that, there have been over 220,000 deaths associated as a result of COVID-19. In the state of Montana, we've had, as of today, just about 26,500 cases, and in Yellowstone County, about 5,700 cases. In regards, and this is a question that I ask very often, is how the disease process of COVID-19, and for the most and although we're in our 9th month of this pandemic, the disease process of how this infection, the timeline of this infection hasn't really has stayed fairly constant. Usually patients who first get infected will present will start having symptoms about 5 days after the infection. However, they are considered to be infectious about 2 days prior to the onset of their symptoms. There is an initial peak in them when they're considered to be infectious, but then the amount of virus that's being shed by an infected person will drop after about a week, typically about a week and a half to 2 weeks, depending on certain circumstances such as severity of illness, as well as any other underlying medical issues such as immunosuppressions. So, this is kind of a great schematic of the clinical timeline of COVID-19, where the peak viral loads really starts about 2 days prior to the onset of symptoms, and then kind of last about 5 to 7 days after the onset of the symptoms. So, viable virus in most patients are detectable up to day 10 after the onset of symptoms, and then, but in some of those who have again a severe illness or immunosuppression, that the isolation of viable virus has been found to up to day 20. Now, now I would like to point out, because this is a question that's asked quite often, is that should we still test for patients after that? And the answer is that you, if you're testing for the purpose of determining if someone is still considered infectious, the answer is probably no. And that is because it is well known now that viable that RNA fragments are continue to be detectable from day 20 all the way up for several weeks through even a couple of months after the initial onset of symptoms. So, because of that, the CDC has modified their original discontinuation of isolation guidelines from a test-based strategy, that is having to have 2 serial negative tests, to a time-based strategy where majority of patients who are either mild or have mild to moderate symptoms could be taken out of isolation 10 days after the onset of their symptoms, or for those who are more severely ill or critically ill, and or have a severe immunosuppression, that they can be taken out of isolation after 20 days from the onset of symptoms. Now, for patients, those asymptomatic patients who have been tested positive, it's typically 10 days after the 10 days from the day when the test was performed, as long as they did not develop any symptoms during the 10-day period. Now, in regards to treatment, we typically look at in 3 phases. These phases correspond to the disease process. In the beginning, shortly after the infection or inoculation, the patient goes through a viremic phase, during which the virus is actively replicating. And this is that period is still, and how long that lasts is really kind of variable, because it depends on comorbidity, host factors, things like that. But typically, again, that this will usually this viremic phase kind of lasts for probably about 5, maybe up to 7 days after the initial inoculation, but can certainly up to about 14 days. As their disease progresses, they will then transition into a pulmonary phase, where they just develop more of respiratory symptoms. So this is typically where most of our clinicians see these patients, where they come in with shortness of breath and cough and just not feeling very well. And depending on the circumstances, most patients with COVID-19 will recover. And as a matter of fact, the numbers is still about 80% of patients who have come down with COVID-19 are fairly mild and moderate, and they usually improve on their own. But a handful, about 20% of patients, will then transition to more of a severe phase, where as a response to the infection, there is there's a significant increase in this host inflammatory response, where the body kind of starts as a reaction to the infection, it becomes trying to fend off the infection. Also does other release a lot of cytokines, and this is where the cytokine storm comes from, where there's more of cause more damage to to the host tissue in response to the infection. And now I wanted to point out the schematic mainly because treatments are directed to each of the specific 3 phases, and that the efficacy of the treatment really depends on when the treatment are initiated and during which phase these treatments are initiated. Now, I want to kind of start off with Remdesivir because this is the big hot drug and that this has kind of been talked about quite often. And now, just as of yesterday, the FDA has approved this for use for COVID-19, officially approved this for the use on patients with COVID-19. And just to really kind of go through what this drug is, it's a nucleotide prologue of adenosine. Just was developed during the Ebola epidemic. So this drug's actually been around for several years. It was found to be active against SARS-CoV-2 in many of the in vitro studies and in vivo studies in macaque monkeys, which is actually what led to exploration of whether this could be used in patients with COVID-19. And the FDA approved it for emergency use authorization back in May 1st of 2020. Now, for this drug, you typically have a loading dose of about 200 milligrams followed on the first day, followed by 100 milligrams daily for the subsequent days, up to 10 days. Some of the things to kind of note about the use of this medication is that it should be used in caution for in patients with elevated ALT or those with chronic kidney disease. And the reason for the latter is because the injection contains cyclodextrin, which can accumulate in patients with poor renal functions. The other thing to really want to point out is that, although not very common, is that there have been some reports of significant drug-drug interactions leading to hepatotoxicity. And this is actually one of the reasons to use in caution in patients with ALTs that's about at least 5 times the upper limit of normal. Now, I want to kind of go through some of the studies that was led to that have evaluated the use of Remdesivir. The first one is the ACT trial, which was actually performed by the NIH. And this was a double-blinded randomized placebo trial that involved about just a little bit over 1,000 hospitalized patients. What they found was that the median time of recovery for those patients who are treated with Remdesivir was significantly shorter than those patients who received placebo. So those received patients who have received Remdesivir had recovered in 10 days, whereas those who have received placebo about 15 days. Now, the other thing that the study has pointed out is that the mortality at day 15 was also much better in those patients who received Remdesivir. That is 6.7% compared to those who received placebo, about 12% mortality. At day 28, there continued to have significant improvement in the Remdesivir treated group, that the mortality is at just a little bit over 11% versus those treated with placebo, about 15%. However, one of the things that was notable, even though there has been improvement, there has been no difference in the initiation of the time of discharge patients receiving standard of care or Remdesivir at day 29. So here's the study that was published in the New England Journal, that the overall recovery of patients who are treated with Remdesivir significantly improved when compared to that of the placebo. So that is the Kaplan-Meier graph on the left upper corner. And then they have stratified to different other groups, such as those who are not receiving oxygen versus those who are receiving oxygen. So there are some that show some improvement. However, in patients who are receiving high flow oxygen or non-invasive mechanical therapy, ventilation, there is improvement at day 15, but this seems to have gone away by day 28. So, and the other thing to notice is those patients who were on mechanical ventilation or ECMO, there's been no really significant improvement in outcome, whether or not they've received Remdesivir. And then if you look at just to kind of break down in the different test groups, again, the recovery rate ratio of all these patients seems to kind of favored the treatment group versus the placebo group. Although there is still, the confidence interval do cross the line. So in some circumstances may not be as well as others. Now, the second big study, which was just recently released, but it has not been peer-reviewed or published, is the Solidarity study. This is the study that was performed by the WHO and involved about 40 countries. It is an open-labeled, randomized control study that involved about 2,700 hospitalized patients. What they've shown in this study is that the overall mortality of those patients received remdesivir compared to those who are on control, there were no difference, and that there were no difference in the two groups. For those patients who are still hospitalized at day 7, that there were more patients still remaining hospitalized who were received remdesivir when that compared to that of control. So this kind of poses a little. The study is certainly compared to that of the ACT study is certainly say very differently, definitely have a different conclusion, and a lot of the infectious disease community has kind of questioned whether the FDA approval of remdesivir had included the evaluation of the Solidarity study, and certainly without having it being peer reviewed and published. There is some question, even though that part of the reason that wasn't taken into account of. So I think that, this is certainly something to take note of as we use quite a bit of remdesivir, and the question is really, does it really make from locally, and we'll have the discussion later, has that make an impact on the mortality of our patients with COVID-19? Now, so this is the guidelines for use of remdesivir in COVID-19 by the NIH and IDSA. So for NIH, there's really no recommendations. There are no recommendations, not recommended. So I want to differentiate that. Is that in those patients with mild to moderate illness. However, they do recommend. They do recommend those in use. Remdesivir in patients who do not require high flow oxygen in non-invasive ventilation, invasive ventilation, or ECMO, and that they suggest 5 days of treatment or until the day of discharge, whichever comes first. But they also have offered no recommendations, whether for or against the use of remdesivir in those patients with supplemental oxygen, other than nasal cannula. So it's really what they really recommend. NIH is those patients who are on just pretty much nasal cannula oxygen, they recommend its use, but otherwise they have no recommendation for or against in other groups. For IDSA, IDSA recommends use of remdesivir in all patients who require supplemental oxygen. So it doesn't matter whether it's nasal cannula or those who are receiving being intubated. Now, they do differentiate the treatment duration of the groups, that those who do not require invasive mechanical ventilation or on ECMO, that they recommend a 5-day treatment, whereas those who are more severely ill requiring invasive mechanical ventilation or ECMO, that to extend the treatment to 10 days. However, they agree, however, they have made a very specific recommendation against the use of remdesivir in those patients who do not require supplemental oxygen. Now, so the next drug that we commonly use in the management of dexamethasone, in treatment of COVID-19 is dexamethasone. And just for this, just to really recap what dexamethasone is, it's a synthetic adrenocorticosteroid, which has pretty much exclusive glucocorticoid action without any of the sodium retaining properties. And there's various clinical indications for the use of this drug, and this drug has been around for a very, very long time. But this time, it's actually not been FDA approved for use or even under emergency use authorization, as far as I know, for in COVID-19. Now, For dexamethasone, the NIH recommendation for its use is in all patients who are requiring supplemental oxygen or requirement of mechanical ventilation. So they require it for everyone who needs oxygen, but that they recommend a treatment duration of 10 days or until discharge, whenever it comes first. However, they were very specific in that they do recommend against its use in any patients with COVID-19 who do not require supplemental oxygen. As IDSA pretty much echoes what NIH suggested, as that they recommend the treatment of all patients with COVID-19 requiring oxygen. Now they cut it different. They were a little bit more specific in what they said is that all patients who are considered critically ill should receive dexamethasone, as well as those who are hospitalized for severe illness. But however, they didn't go into detail just those who do need oxygen. And I will kind of explain how that shortly how they define that. But all patients who are not severely ill and not requiring oxygen, which recommend against the use of dexamethasone. Now, with the IDSA, the reason that they didn't specifically say compared to that of NIH is because they had to find any patients who require supplemental oxygen to be at minimally to be considered severely ill. So essentially, it's pretty much for those hospitalized patients who require any hospitalized patients who require oxygen should be placed on dexamethasone. Now, the study that kind of led to support of use of dexamethasone, there are twofold. One is the recovery study. And this is, again, done by the WHO. Now, this is a controlled but an open label study that enrolled about 6,400 patients. Now, and what they found is that the overall incidence of death within 28 days is significantly lower, statistically lower, in those patients who receive dexamethasone compared to that of standard of care alone. Moreover, that they stratified to those patients who are incident of death who are mechanically ventilated, that they notice a significant lower in those who are treated with dexamethasone and when compared to standard of care. And then finally, that they also showed some improvement in the incidence of death in patients who are moderately ill but do not require supplemental oxygen. They show that dexamethasone seems to be a little bit higher than that of standard of care. So in this study, they really showed that the improvement that dexamethasone had done showed improvement in those patients who are treated with dexamethasone who require supplemental oxygen, but not those who do not require oxygen. And this is, as I mentioned, this is a study, and this is published in a New England Journal. They're saying the overall the rate incident of death in patients who receive dexamethasone is significantly better, lower than those who have not received dexamethasone. And this was shown both in patients who required just supplemental oxygen or invasive mechanical ventilation. However, in patients who do not requiring supplemental oxygen, they actually tend to do a little worse. And again, this is just kind of looking at the rate ratios that those who require oxygen do better and benefit with dexamethasone than those who do than not receiving dexamethasone, except for those who are not requiring oxygen. Another study that which kind of showed the use of supports the use of dexamethasone is the Codex study. This was recently published in JAMA, and this is a randomized open label trial that involved multiple centers. They enrolled about almost 300 patients. They've shown that that patients who received dexamethasone had more ventilator-free days, then those are standard care. And sorry, that's a typo, not percent, but it's days. And that for those patients who are in the intensive care unit, that their SOFA scores tend to be lower at day 7 than those who did not receive dexamethasone. However, however, they noticed that there were no statistical differences in between the two groups in all causes of mortality at day 28, nor ICU free days or ventilator day free days, all at day 28. So this is just a slide that the article has shown that just outlined the study and showing that what they've done, where they looked at, and the patients that looked at, how they randomized, and their finding of those patients tend to do better on dexamethasone and standard care. One thing I do want to point out is that, and I will try to list the dosage of dexamethasone, that this study used much higher doses of dexamethasone than what we typically use here at Billings Clinic. So they're using 20 milligrams of dexamethasone for 5 days, followed by 10 milligrams of dexamethasone per day for 5 days after that. So they're using much higher doses of dexamethasone. And again, here is just showing that the day alive and days of ventilator free, that it was patients tend to do better with dexamethasone than when compared to standard of care. All the way, but at day 28, there was no difference. This is a meta-analysis that's looked at different studies evaluating the use of corticosteroids in the treatment of COVID-19. And in general, it's that treatment what this analysis has found that treatment with steroids seem to have a much better patients who have received treatment with steroids tend to have a better outcome than those patients who do not receive steroids. And just to kind of talk about is that I've been focusing more on dexamethasone, but other steroids have been evaluated and have shown some efficacy. This was a study that was published in the European Respiratory Journal. That was a study that was performed in Iran. It's a single-blinded, randomized control study that looked at 68 patients half of which received methylprednisolone at 250 milligrams a day for 3 days. All patients were found to were enrolled had hypoxia, and what they've shown is that there were a clinical improvement about those who received methylprednisolone show significant improvement compared to those who received standard care. Moreover, they've also showed that those who received methylprednisolone had a much lower mortality than those who received standard care. So, as I mentioned earlier, is that we looked at corticosteroids. I've been focusing most primarily on dexamethasone, and this is pretty much what the dosage of 6 milligrams per day for up to 10 days has been is the recommended dosage by both NIH and IDSA. Other steroids can be used, such as hydrocortisone at 160 milligrams per day, methylprednisolone 32 milligrams a day, or prednisone at 40 milligrams a day. And then the third of the big drugs that or therapy that we use in the treatment of COVID-19 is convalescent plasma. So convalescent plasma is essentially plasma that's collected from those who are sorry, and I missed typo there, is those are from COVID-19 recovered individuals. And this concept of use of convalescent plasma for infectious disease is not novel. It's been around for quite some time. Actually, there was some discussion about use in the pre-antibiotic days, but or at least early on in the 40s and 50s. But the idea is that those who have been infected with a specific pathogen have neutralizing antibodies. So in this context, is that it's felt that the patients who are recovered from COVID-19 will have neutralizing antibodies against SARS-CoV-2. Fortunately, we don't know what the optimal IgG titer for neutralizing antibodies from the donor or the treatment dose needed to be effective. So many of these convalescent plasma that we've collected is really, we certainly have a standard of saying minimal of titer to be considered acceptable, but we just don't know if that, what is the actual titer that the plasma contain that would be felt to be considered effective. Nevertheless, as probably heard, is that this was announced to be approved through emergency use authorization back in the end of August. The dosage is typically 1 to 2 units, usually 1 unit for the majority of the time, but occasionally we'll have 2 units units per patients. Now, and per hospital. And there's really no other studies on using more, or do you wait for another a week or so to have another dosages? There've been no studies that I'm aware of that look at if there's any repeat dose will actually show any added benefits. Now, just to note that there have been transfusion-related reactions reported, and I know that at Billings Clinic we have had used convalescent plasma in many patients, and that we have had a handful of transfusion-related reactions. So that's to note. The other is that because there is a fair bit of volume in this, is that want to kind of take note that you want to use this with caution in those who are very volume sensitive patients, such as those with heart failure. Unlike most other studies of remdesivir and dexamethasone, there's really limited data on the use of convalescent plasma. And so therefore, both IDSA and NIH have no recommendation for or against the use of convalescent plasma. And IDSA has really only recommended this use in the context of a clinical trial. Now, there are the 2 studies that have looked at convalescent plasma are listed here. The one on the left by Lee and others are done in China, and which involve 103 patients. And what they have shown is that there was really no statistically significant improvement in those patients who received convalescent plasma when compared to that of standard care. And this was more applied to those patients who are severe or having severe or life-threatening COVID-19. The other study is the CON-COVID study that involved 86 patients. They also showed that there were no statistical difference in mortality or 15-day disease severity in patients who have received patients with COVID-19 who have received convalescent plasma. Now, one thing that they noted in this study is that many of these patients who have been of their enrolled patients already had anti-SARS-CoV-2 antibodies at baseline. So, again, they want to kind of point this out, but the study really didn't go into details of what is the clinical significance of that particular findings. So, and then I kind of want to end this segment of the discussion with just to kind of point out some of the other proposed investigative therapeutics. We have kind of looked at you probably have heard either through medical literature or the news media some of the studies such as hydroxychloroquine, which I'll kind of should go into detail in a moment, but others such as lopinavir and ritonavir, which is Kaletra, and as well as ivermectin. Blood products such as IVIGs with specific SARS-CoV-2 antibodies, not IVIG SARS-CoV-2 antibodies, as well as mesenchymal stem cells have been currently being investigated. There are immunomodulators such as IL-1 inhibitors, IL-6 inhibitors, which is probably the most common one, and that's talked about one is tocilizumab, as well as JAK and Bruton's tyrosine kinase inhibitors, as well as interferons. And finally, other various drugs such as famotidine, anticoagulants, vitamin C, vitamin D, vitamin E, and zinc supplementations have been investigated. all these studies have kind of had very limited studies, and unfortunately most of them don't have had shown any significant clinical improvement when COVID-19 patients have been treated with those therapies. This was a recent study that was just published from the Recovery Collaborative Group on hydroxychloroquine, and this is really kind of looking at hydroxychloroquine versus usual care, and what they've shown is that really no, maybe modest but mild modest improvement in mortality, but overall, however, is still not considered to be statistically significant. When we look at different different groups on the use of hydroxychloroquine at mortality at 28 days, even though it looks like it may favor it looks like what they're showing is that most of this is that hydroxychloroquine has not shown really any significant improvement in mortality. And then the use of hydroxychloroquine for post-exposure prophylaxis has shown that it doesn't really kind of prevent the onset of COVID-19. When compared to the treatment group versus the placebo group, there were no statistical differences. And then, so to end the segment of this presentation, I kind of want to point out, because we get a lot of questions, and I think that there's so much data out there that it's really and it's all over the place. IDSA as well as the CDC has collaborated and put together a website where frontline clinicians can kind of gather all these information, not just on treatment, but infection control, infection prevention, management, all these things that related to COVID-19 and one website. And this is kept up to date on a regular basis. So it's just a good, again, a good resource for those, especially out in the rural setting, to kind of look up for any specific questions you may have regarding COVID-19. And finally, this is the end of my half of the presentation, and then I'm just going to open this up to some panel discussion. And if you have any question, please just put in the chat box, and we'll kind of render have our panelists renders our experiences and our opinions about about the questions.
Thank you, Dr. Koo. That was wonderful. We do have some questions in the box. I'm happy to read them for the panel, or if there's somebody who wants to volunteer to read them from the panel. The first question is, any role for outpatient steroids, oral or inhaled?
I think pretty much from my standpoint, the answer is probably no, based on the dexamethasone data showing that actually those patients who did not require oxygen supplements did worse with their infection.
Go ahead.
Yeah, and I would, I agree with Evan there. There actually been no studies on looking at that I'm aware of that looked at using inhaled steroids for the treatment of COVID-19. But given that steroids, that the recovery study that looked at dexamethasone on those patients who are not requiring oxygen, and I'm going to assume that majority of that's going to be pretty much almost all your patients who are on the outpatient setting, where because then they tend because they have a worse outcome. I wouldn't recommend the use of steroids in general in an outpatient setting.
Thank you. Related to that, there was a second question, it looks like from the same person. Any role for aspirin after discharge, specifically on patients with elevated D-dimer and not proven clot?
I'll go take a stab at that one. Unfortunately, there's really not, I don't have an answer to that because there was really no studies, or no one really looked into correlating D-dimer in this situation. I mean, I don't think that I have a really a opinion on this. I know that thromboembolic event has been reported as a complication of COVID-19. Most of the reports are kind of have been really focused on at finding this pulmonary embolism or a DVT as part of an incidental finding. But as far as any studies and looking at proactively looking for the risk of a thromboembolic event using D-dimer, that has not been investigated in this context.
Thank you. Then the next person, so starting today, can we stop having patients sign consent for Remdesivir?
The answer is probably yes, but each individual hospital or hospital system is going to have to decide their own use of that drug, whether it is a formulary drug, needs ID approval, whatever. So it will be handled like any, high-priced antibiotic that we use these days.
I second that with that. Remdesivir is one of the drugs that's been kind of discussed amongst the antimicrobial stewardship community as a drug that should be kind of be restricted, be authorized instead of being made available. Partly because of the availability, because that there is still a supply issue, but also that this is not a benign medication. As I kind of pointed out earlier, is that that there are there have been reports of significant drug-drug interactions, and so and that causing hepatotoxicity. So certainly that's of a concern. The other is that it contains cyclodextrin, which is something that can accumulate in patients with chronic kidney disease. So I think that just being a relatively new drug, having this to be kind of restricted to with authorization is necessary to ensure that that this is being prescribed appropriately and with minimum risk to the patient.
Thank you. Question 3. Is there any reason that prednisone wouldn't work as well as dexamethasone?
So to answer that question, no. The majority of the studies have been done on dexamethasone. So whether or not that there have not been any comparison study with dexamethasone compared to other corticosteroids. So right now, I can't. I'm not able to tell you that if would prednisone be less effective. I think that if you have dexamethasone, I would prefer that would probably be the preferred agent. But if you're out of dexamethasone and you have prednisone, then it's considered to be a reasonable alternative.
We have a related question from Nancy Iverson. Does ID recommend increasing the dose of dexamethasone from what we are currently using at Billings Clinic?
Let's go to I'll take that one. No, go ahead, Evan.
No, I was just going to say no. I haven't seen any data that suggests that we should be doing that.
And same here. There was that one study that I noted earlier. I mean, whether that it didn't seem like the 20 milligrams for 5 days followed by 10 milligrams for another 5 days didn't. Unfortunately, that didn't seem like that could automatically translate saying higher doses is more effective. Certainly, one of the things that we have to take account of is that there are also other adverse effects of dexamethasone. So it's not just a higher potential could be better, but higher doses can also lead to more other complications associated with therapy. So it's trying to find that balance. So far, that it seems like the 6 milligrams per kilogram, 6 milligrams per day dosage has been adopted by most of the by NIH and IDSA. So I think that it's, I would encourage that we continue with that dosage at this time.
It looks like there's a lot of questions about dexamethasone. So we have another one as well. Does it make a difference whether the dexamethasone is given IV versus PO? We frequently see it given IV in patients that are able to take PO medications.
JC, would you like to comment on that?
So from what we've seen is when patients were able to be converted to oral, they should just be converted to oral. Sometimes it's a convenience thing. Personally, I don't know that it makes a huge, obviously when they're super sick and you have potential absorption issues, we should start IV, but I don't think later on it makes a huge difference.
Great, thank you. Is the convalescent plasma screened for ABO and RH type, so there's a risk of ISO immunization?
I've got that one. So this is Stacy Lee. So I just want to comment just briefly about convalescent plasma in general. This is our week of our National Professional Organizational Meeting, ID Week, and there was an entire 24 hours devoted to COVID and COVID care right now. A lot of that had to do with convalescent plasma. And as what Neil presented is absolutely right. The data that's out there right now is somewhat equivocal. The safety data is pretty good. There are 25 randomized controlled trials that are going on right now, of which some of them will have data available as of November. So there are some exciting things to come in convalescent plasma. It's people who are PIs on those studies are actually quite hopeful about the impact of convalescent plasma, particularly when given earlier. I believe Neil also made a comment about whether we don't know too much about whether we should be giving more than 1 unit. Actually, the Mayo data showed that indeed there did seem to be a dose response. And this is showing up in some of the randomized controlled trials as well. Unfortunately, convalescent plasma is not at an unlimited supply at the moment. So our blood bank supplier Vitalant has needed to limit the convalescent plasma to 1 unit per patient request at the moment, which makes sense. So we don't have the ability to give more than 1 unit at the moment. But again, things might change in the future as we have more available donors and we have more available information. As for the question that was posed, the question was, is the convalescent plasma screened for ABO and RH type? Indeed, it is known that the ABO and RH type of the donor is definitely labeled on the units. Each donor provides about up to 3 units of convalescent plasma that can be used. They do titer out the antibodies in there, but that is not information given to us. That is information kept and shared with the FDA for information purposes and trying to determine what they should do at the FDA level with the convalescent plasma. So I am not the blood bank pathologist, but I do work carefully with him right now. And what he told me was that there is very little risk of giving non-matched units to patients. And in fact, if we were ever at a if we were ever in a situation where we did not have appropriate blood type and RH, he would not be hesitant to give, for example, an A to an O patient. Because there's such a low risk of there being any sort of reaction with the plasma portion of it alone. That said, I can assure you that as of now, we have been giving specific types, including blood type and RH. We've been administering it in a compatible format with our patients. So, for example, a patient may be A positive and get O negative, but obviously you could do that with blood transfusions as well. As for the question of whether there's a risk of isoimmunization, given the way that we're giving the plasma, no, there would not be. But isoimmunization is actually a phenomenon that happens in pregnant women, and it occurs with the fetus. So I'm not sure if this question came from one of our colleagues that is working in obstetrics. But no, I have not heard that come up as a concern. What has come up and is a question, and I don't have a good answer for it, is whether there is alloimmunization that happens with plasma. Again, I doubt that it would be a very big deal, but that is where you develop antibodies to HLA class antigens, and would be a particular concern in transplant patients. However, at this moment, as of listening to the experts on ID Week, people are giving convalescent plasma to transplant patients right now, and of course, it may be too soon to have seen if there's any trouble with that, but there hasn't been to date.
Thank you for that very thorough discussion, Dr. Lee. That was really helpful. We have another question. This one's coming from Carrie BC, and she's asking about proning patients. When is the best time and does it help?
So this is the deal. That's a good question, and I actually didn't go into that very. I think that an intensive is probably better to answer that question. I know that that's been discussed, and there's been and actually it's included into that IDSA real-time learning network website. I know that last I've heard was that there has been some some benefit to proning patients. Although I don't recall seeing when that would happen, but usually, it seems like those patients who are experiencing more respiratory distress or symptoms and may benefit from that. Now, would every patient benefit from this? I don't know, but I could imagine that they would. But other than that, I may have to get back with you with that.
It does sound like that's a question for the maybe our pulmonary critical care department for sure, and I appreciate that referring back to that COVID-19 real-time learning network. Did anyone else want to offer some insight before we move on? So I just want to thank the members of the panel discussion and also those members of the audience that took the time to submit questions. I think we have answered all the questions that were in the box. Thank you everyone for this excellent and very hopeful discussion.
Thanks, everyone. We appreciate you joining us today. Just before we end here, just want to remind you that if you want to receive CME, that you need to click the link that my colleague Ashley has entered into the chat box and fill out the form that's attached there. She's also sent that out via email as well, so you might receive it through that realm. Also want to let you know that if you missed our presentation last week, we do have that available on our website. And Ashley has also sent out that link and made that available for you too. If you have any questions, you can always email us, our CME team at billingsclinic.com. Anyways, have a great rest of your afternoon, and we'll see you soon.